Thank you everybody for attending today's webinar, Uploading Shared Health Summaries and How to Maintain the Momentum. My name is Sarah Raderstein. I'm from the Improvement Foundation. We also have Alison Konachek with us today, and we also have Dr. Tony Lembke. So Tony will be talking today about his experience with digital health, and will be providing some helpful hints, as well as talk about how his team has maintained the momentum. Hopefully by now most practices are up to speed with at least the technical fundamentals of digital health. We realised that it was a lot of work to get all of that into place, and we are hoping that practices are also uploading their shared health summaries and meeting their target. But of course we realise that once you get over the first hump, that you then have to continuously upload shared health summaries, and it does need to become an everyday part of your practice behaviour. So Tony, how is your practice going with that?
Oh, good, Sarah. So you and I had some webinars earlier this year where we talked about some of the fundamentals of participating in the digital health world, and you personally assisted a number of practices, Sarah, to achieve the hippies and the hippos and update their software and get all the tools in place. Most people were successful in achieving that, Sarah. Would that be correct?
Yes, I think so. I think once they got over the hurdles of all the language, like you said, the hippos, the hippies, and there was quite a lot of work to do in the back prior to being able to upload those shared health summaries. We definitely had some practices that were interested in getting help, but most of them in the end were able to get through that process quite easily for themselves.
Yes, so we, Dalford and I had a look at, did some work with ACRM on practices in the digital health world, and they're commencing their journey of being required to upload a number of shared health summaries, and this may have been a common scenario. Sarah, I'd be interested in the people attending the webinar. They may like to tap in the chat pane as we go along how much this reflects their experience as we talk about the scenario, so you can chat in whether it was nothing like what happened to you or a lot like what happened to you. And the scenario is a bit like this, Sarah. I think that sort of people started off with their older computer systems, and their first task was to upgrade them and get all the procedures in place, the fundamentals of digital health, which we've talked about, and that was achieved quite well. They moved on to the brave new world of computing, and most of them were ready to go and had shiny new computers ready for their practice teams to use. So they were ready for that. So then the next step that most practices did was call a meeting of all their clinicians to discuss the shared health summary requirements. And at many of these meetings, the practice managers and practice owners said, chaps and ladies, we've got a requirement now to upload 25 or 30 or 35 shared health summaries every quarter to the new My Health record. And we need to get cracking on this. The government has made this as a requirement, so we'd like you all to get started. I've got some paperwork here with clear instructions as to how you upload a shared health summary, and so I'd like you all to get started, and away you go. So that happened in many practices that we've spoken to. The equipment was ready, the information was given. But just a week before the time came to check at the end of the quarter, at the end of August, how we were going, horror of horrors. To their surprise, many practice managers found that most doctors hadn't uploaded any shared health summaries, and some doctors had uploaded a few, but they were well short of the target. So I wonder if that was the experience of some of our practices. The practice principals, with the approaching deadline, knuckled down, and with the assistance of the practice nurse and the practice manager, spent the last week of the quarter uploading as many shared health summaries as they could, and eventually got over the line. We know that most practices, of the 6,000 practices registered for the EPIP, I think the number's about 3,500, might be 5,000, 3,500 anyway, made the deadline, and another 1,500 or so missed out. I think that's the figures.
Yeah.
So is that your understanding, Sarah?
Yes, absolutely, and I think you're right. I think it was just people getting over the line. And what do you think, Tony, some of the barriers were for the practices?
Well, I think with the practice we've spoken to, many of the doctors didn't feel that it was significantly helpful enough for their patients to be that they upload Shared Health Summaries, because they were aware that there wasn't a great pool of people who were reading them. Many doctors didn't feel they were masters of the technically of what they had to do. They weren't all over it, and people, particularly in medicine and in health, don't like doing things where they don't look masterful at it. So they didn't feel confident about their skills to do it. They weren't happy, many doctors, that they were being appropriately financially rewarded for it, and they found it quite clunky and difficult to learn new skills. So that combination of not being sure it was worthwhile, not quite having all the skills they needed, not being sure about the financing arrangements, meant that many practices, although they had the tools in place and were ready to go, didn't meet their targets. And those that did, many of them that we've spoken to, Sarah, feel that they made it this time by the skin of the teeth just before the deadline, but are not confident that they've got the systems in place to manage this into the future, and can see a future where it's all running to deadlines every quarter with a struggle to get over the line.
Yes, that's right. I mean, you don't want to be dreading each and every cut-off date and it being a scramble to the finish. So really, without having proper plans in place, or without it becoming part of the daily routine, it just becomes a stressful quarterly event. Now, I have heard that the last cut-off date has been extended. Is that right, Tony?
Yeah, so practices who miss the cut-off date have got a period of time that the Department of Health won't take away their EPIP as long as they make up those numbers over the next few months. So it gives us all a chance to develop a new approach to systematically uploading Shared Health Summaries.
Yeah. So your practice, Tony, has a quality improvement approach. Is that correct? And what does that entail?
So Sarah, we thought that we'd go back to the basics and look at some of the skills that we learned from participating in the Collaboratives program for many years. And a lot of those, in implementing any improvement program, I think there are certain fundamentals that need to take place. And if you're going to lead change in your practice, you need to make sure that you've dealt with these. So some of the principles from the Collaboratives included engaging your practice team with a meaningful aim of what you're trying to achieve, of looking at the systems in place in your practice and not blaming individual people, but developing systems to support them, taking small incremental steps, undergoing rapid change cycles, stealing shamelessly some of the ideas from other people, and then a focus on measurement, being the oxidative improvement, so measuring and feeding that back to your team to develop that spirit of a culture of Kaizen, of consistent improvement in the practice. So I think we've thought about going back and developing a quality improvement approach that would encourage all these principles. I think, Sarah, that one of the key aspects is leading around this is leading change in your practice, having the skills that can engage your practice team in the process, activate them, and give them the motivation that they need to participate with you.
Yeah, and how does that work for your practice?
Well, we were informed a bit by a previous qiCommunity webinar, Sarah, that we did with Paul Plasek and Julie Johnson. And Paul Plasek talked about how to lead change in a practice. He's a professor from America who works for the Institute of Healthcare Improvement over there and studies how you lead change in health. So I'll remind you of what happened in that webinar. Paul said that we think that instigating change in our practice is similar to the process of trying to throw a rock and hitting a target. We're trying to hit a target, we're throwing a rock. And then it's all about what we do, how we launch it, the angle we project it at, the force that we give to the rock determines where it ends up. And with the passage of time and some experience, we can get the skills to always hit the target. We undertake change processes in our practice as if that was the way that we lead people. But in fact, Professor Plesek pointed out, in fact, when we're leading change in health, we're not throwing rocks at target, it's more like we're throwing birds at target, and birds at a target, throwing a bird. And Paul said, when you throw a bird at a target, it's more about what the bird wants to do. The bird chooses whether to follow the trajectory that you anticipated for it. So it's more about what happens with the bird than it is about how you launch it and what your intentions are. And he said many people lead change because they don't understand the team's motivations that well enough, and they think it's all about them. And therefore he says the way to be successful when we're throwing a bird at a target, Sarah, is to have the right bird seed and to put it at the right place. So you need to find out the motivators or the activators or the potentiators of our team, and then we'll have no trouble hitting the target. I mean, birds are better at flying. They know more about flying than we do. They know how to fly. We just need to give them release them and give them the right motivation to reach the target that we're trying to reach. So we've informed by that approach of leading change, Sarah, we developed an improvement map for this particular program in uploading Shared Health Summaries.
Great. All right, so firstly, you want to define the aim.
That's right. So an improvement map is a framework that we use for change in our practice. It's an A, B, C, D approach before we instigate any change. So an A, B, C, D approach. So the aim is the first step, A for aim, A for aim. And then any improvement project requires an aim that's meaningful to the team that will be implementing the change, and preferably an aim that's measurable so we can determine our progress towards it. And so in this particular Shared Health Summary aim, if we say to our team our aim is to get the EPIP, or our aim is to upload a nominated number of Shared Health Summaries each month, that may not be an aim that that they feel motivates them or is of interest to them. It may be or it may not be. We need to be careful when stating our aim that it's both clear, measurable and meaningful to the participants. So we'll come back and have a think about later on, Sarah, about what an aim might be for this Shared Health Summary project.
Great. Great. So A is for aim, and what does B stand for?
So the B is for benefits. So when you and your smaller team have worked out what the aim is, then it's important to highlight the benefits, which is the bird seed. What's the bird seed? What's in it for our team? And so we think of benefits in health, we break that up into 4 particular types of benefits, and we think it's important to hit up on all of those. So we say that what's the benefit for the patient's health? How do they get better patient health outcomes? Why is it better for the patient experience of receiving care? How does it make a better experience for the clinicians delivering the care? So how does it make life easier for the clinicians and not harder? And what's the business case? How does it help the practice bottom line? So when a practice is undertaking a new program like this, like instigating systematic shared health summaries, it's important that they say, why is it better for patients' health? How does it improve their experience of care through the system? How does it make it easier for our clinicians to deliver the high quality care that they want to deliver? And why is it better for the practice bottom line? It's also important when you're planning this to look at the disbenefits, which is a rather ugly word but quite a useful one. That is, what's going to be worse when we instigate this program? Because if you don't think when you're planning the program of all the ways it can be worse, you can be sure that your team will think of them very quickly and tell you what are going to be the problems in the system. So it makes sense for you to have thought about what might make it worse and have worked out what measures you can use to measure that. So Sarah, the B part is thinking of the benefits or the birdseed, and always in those 4 categories. And how are you going to measure those benefits is the other part. So before we go to our team, we have the benefits and the measures that we plan to use them, and that motivates us. So now we can think and encourage the people who are contributing, participating in the webinar to think about how does Shared Health Summaries help patients' health? How do they make the experience better? Why? How does it make it easier for the clinicians? How does it improve the practice bottom line? And what could be worse? And we've discussed it before. I think it's helpful for practice to think about some of those issues themselves and drawing it up, their own improvement maps with their aims and their benefits.
Great. So we have the aims and we have the benefits. Now what does C stand for?
So the C, Sarah, is the course you're going to set or the changes that you're going to make. So C for changes really, or the course that you're going to set. And these are improvement ideas, often classified change principles with improvement ideas classified beneath them, that your practice will come up with to achieve the aims and benefits that you've enunciated. And so we get improvement ideas either from stealing shamelessly from elsewhere or by brainstorming ideas in our own practice. So we know where we're going, we know our aim, we know what the benefits will be, what's the treasure chest that we're after. Then we work out how we're going to get there, what are the course we're going to set, what are the ideas we need to implement. And for this particular program, Sarah, we have previously done some work in the qiCommunity, and these were the general principles for the improvement ideas, the change principles that were used in the qiCollaborative program. There were 6 of them. And beneath those sit a number of improvement ideas. So nearly always our first change principle is to engage your practice team in the program and the journey. The second one was to undertake the foundational work for My Health Record, and we know that many practices have done that successfully. The third one is to improve the data quality in your own systems so that it's up to scratch and suitable for sharing. The fourth one is to develop systems to support Shared Health Summary uploads. The fifth one is to engage your patients in the practice in My Health Record, make them feel some ownership of their health record and participate in your systems for uploading. And the final one is to spread the use of Shared Health Summaries and My Health Record across the patient's entire care team. So work with the allied health specialists and hospitals that you work with so that the Shared Health Summary is a benefit to their patient in an integrated way throughout their care team. So, so they're the change principles there that we would use them beneath each of those, and is the number of change ideas that practices can take up. And we can talk about some of those change ideas later, and I'm going to tell you a resource where many of them are listed.
Great. So we have aim, we have benefit, we have change or course, and what's D?
So D stands for doing stuff. So when you know where you want to go and you know why you're going there and you know the course you're going to set, you actually have to set sail. And many of our practices spend too much time only doing the A, B, and C, not doing the D stuff. And you'll remember that the D needs to be very small steps. You can test a change. Start with one patient, one doctor, on one appointment, and then see how that goes. So we have to, in the past, talked about PDSA cycles. In our practice, we talk about, I think this is a bit easier, we talk about plan, act, and check. This is our to-do list. Our to-do list is our series of steps that we need to take and the plans for them. We act on each one in the to-do list and check to see whether it worked. And each of these little packs, when you check it, it has to produce another action. There's a relentless search for what is the next action. But doing it in small steps, and as you take the small steps, of course, you get closer and closer to your goal. So that's the basic process.
Yeah, and small steps means you're not using too many resources or time or financially. So it's just testing change in your practice before you implement a big change, which may seem unsuccessful and then may put you off doing it where there is an answer. You just need to check it by doing small steps along the way.
Absolutely.
Yeah. So Tony, in your practice, Sorry, my apologies.
Yep.
I was going to ask, so in your practice, what was your aim? What aim did you come up with for uploading shared health summaries?
Well, when we met, Sarah, we felt that the patients in our practice who would benefit most from having shared health summaries uploaded to the My Health record were those patients that we managed under the extended primary care scheme, or the patients upon whom we're doing care plans and team care arrangements, are the ones with chronic disease. So we already have systems in place to routinely see those patients, and we felt, and our doctors felt, that they're the patients who would benefit, and that we should make it a routine part of practice that every time we do a 721 or a 732, a care plan or a care plan review, that we update that patient's shared health summary. And as it turns out, they're the ones that are most used. So we had a specific aim, which is that 50% of our patients that we are managing under the EPC program have a shared health summary uploaded, or have had one uploaded or updated in the last 6 months, and we want to achieve that within the first 12 months of the program. So that'll be by the middle of next year. So June the 30th is our target. So that's a clear and stated goal. We met with our practice team to see whether they felt that was meaningful, and they agreed. That that was an activity that they thought would be of benefit to our patients. And we outlined for them the benefits for the patients, for them, for the patient's experience, and also for the practice bottom line. So that was our stated aim, and the benefit.
Yeah. So I've just got a couple of questions in the chat pane, and it might be pertinent to ask them now, Tony. So Sarah says that they don't really understand how to explain to patients what the consent form is for.
Well,
do you have any suggestions?
So we do. So we've trained all the staff with a bit of a spiel of what it's about, and we really, once it's explained that it's for the patient's benefit, the patients are really quite keen. Often they assume that this has been happening already. So the spiel goes that there is now a national My Health record where we can put a summary of your health care, including the medications, the allergies, your past history, and your immunisation history. And the advantage is that if you're travelling or injured or have to go to hospital, that the doctors and nurses looking after you will be able to have accurate information about your health. So we think this is quite a good idea. What do you think? And they say, well, that sounds like a good idea 99% of the time. And then we say that the system they tell us that the system is very safe and secure and can be only accessed by health professionals, but we don't really believe that, and we assume it will get hacked at some point. And they just laugh and go, yep, that seems to be the way that all these things happen. And so, and the receptionist says, so would you like me to sign you up for that? And the response to that in our practice area has been almost universal. Nearly everybody thinks, that's a good idea, can you sign me up? So in our systems, when the patients come to for a chronic disease appointment, the receptionist will have that conversation with them. If they agree with that, the receptionist will do the assisted registration. Then they see the practice nurse who will talk to them about their shared health summary. And when they see the doctors, because these are patients we're seeing regularly, and because we're doing doing care plans on them, their records are up to date with their current problems, past history, medications, and if they're not, we make sure they are, and we upload it. We show it to the patient, upload it on the spot. Really, it's very quick. So I know that doctors are very hesitant about doing it, but once it's part of your rhythm in the practice, from the doctor's point of view, there's very little extra work involved, and it's also excellent engagement with the patients to show them what we think's wrong with them. They appreciate the fact that we're interested in doing that, and that we do have a complete history for them. They'll certainly point out if it's not, and then we upload it, which is just a click of a button. And so we do that, Sarah, every time they come for a chronic disease appointment. That's part of what we do, and it's become routine.
Yeah, what I like about that, Tony, is it's a real whole team approach, which is great, and everybody's role is utilising their sort of expertise. So reception are doing a lot of the admin-y side of things, and then the GPs are going over the medications, going over the history, and then simply uploading it, which is fantastic. I also have another question from Janet. And before I go on, thank you, Sally, for putting that a link to some information for people. But Janet's question is, do you have to gain permission from the patient every time you upload a health summary, or is it the initial consent, which is all that is required?
So we get consent every time we upload it, because we do it when the patient is with us at the time. So we say, we should upload your health summary, and they go, well, that's a good idea, and so away you go. So that's a click of a button. So it is meant to be done by the patient's nominated curator of their health record, which is their GP. So we don't have, the nurses can come and help the GP upload it until they master it, but we do it as part of that general practice part of the consultation. There's no problem with the nurse actually doing the technical aspect of it or doing it under the direction of the GP. But we always have the patient present at the time, or on the telephone if I'm talking to them and I say, I should upload your Shared Health Summary, so that we've got that ongoing consent. There's a question from Brian about excluding information. They don't, I'm often more keen to exclude stuff than they are, like if, there's some stuff on their records that may not be relevant at all, and that can be hidden from the Shared Health Summary. Sometimes there would be stuff that patients don't want put up there, and I'll suggest that to them if I think that's appropriate. Remember that patients can tell the accident and emergency stuff whatever they want about their past history, so we maintain their right to say what goes in it. But our patients, it hasn't been an issue for them wanting stuff excluded, and there's certainly never been stuff that they want excluded that I don't think should be excluded.
And just a couple of other things while we're addressing some of the chat pane is, Rebecca, practice nurses, registered nurses can upload Shared Health Summaries, and I think Sarah also confirmed that down below. And now somebody mentioned that they cannot get their GPs to upload the Shared Health Summaries, which is unfortunate, and that's something that obviously the practice would have to focus on. But again, the nurses, if they can help them, and somebody did mention below that the nurses can come up and help the GPs with uploading them, I'm sure once the GP sees just how easy it is to upload those Shared Health Summaries, that once they get the hang of it, they won't need the nurses for very long.
Well, that's right, Sarah, and I think the point of the analogy of the bird and the rock is that if someone's not behaving in the way that you want them to behave, you need to, that's because you don't understand them well enough at the moment. You need to work out what motivates them and what their birdseed is. And if they're not doing what you think is perfectly reasonable, no point berating them, but more think about what their motivators and drivers are. And so that's sort of the reason we mention that approach. It's not always that easy.
So Tony,
but sometimes doctors...
Sorry, keep going.
I was going to say, sometimes doctors respond to a bit of competition, Sarah, and that was one of the strategies we used in our practice. So this is our notice board in our lunchroom. There's our Wi-Fi password if you want to come into our tea room and use the Wi-Fi. So we've got a horse race running. This is the Shared Health Submarine Cup, and it's just reset on November the 1st. So you can see that, yes, I'm out in front at the moment. I didn't win the last cup. Luke did me in. You can see that the 1st of May to 31st of July over there in the red, we've got 101 Shared Health Summaries uploaded. It's 1st of August to 31st of October, we got up to 176. So we hope to beat that this quarter as we systematise it more. But we can all see where we're going every time we're in the tea room, and everybody else can. And this has been quite a motivator. You can see that Paul is facing backwards down that bottom left-hand corner. Hasn't participated and probably will be one of those doctors who will choose not to participate. I haven't worked out the birdseed, how much birdseed we need to get Paul to participate, but we've got everyone else on board. Mike's one of the registrars, still on his little rocking horse there and hasn't got going. That's probably because he doesn't have that quite that load of chronic care patients that we have. And Jimmy's been on holiday. So this has been quite a good tool, I think, to let everybody keep track of how we're tracking as a practice as a whole and to drive some individual competition around it. I would think there's some discussion on the chat. I would think that you want your GPs to be curating and uploading these Shared Health Summaries, and that's certainly the intention. Certainly the intention of the project. Nurses can upload them under the direction of the GPs, but I would think that it's a GP patient. That's my thoughts about how this should happen.
Well, I love that, Tony. I love the board. I think it's fantastic. It's simple, it's easy, and yeah, I would be motivated by that. I would want my horse to win. Not that I'm competitive.
I haven't won yet, Sarah. So, but maybe I'll report Tony. Back to you that I've won the next one.
Yeah. Great. So we have the aims, we have benefits, we have changes, and we have the doing, which is just, it's simple, it's beautiful in its simplicity, and it just makes perfect sense.
Yeah, so we use that for all our, if someone comes up with an idea at the program, we don't consider it now until they've worked out the aims, benefits and the general changes, and then we brainstorm more improvement ideas around that. Otherwise we tend to talk about stuff a lot and not actually do it.
Yeah.
But if someone says, we really need to improve the way we do health assessments here, we say, great, fill out an improvement map and we'll have a go at it. And so that's the way we do that.
Okay, so we're actually sort of almost about to run out of time, so I'm apologising for running over. Please feel free to stay. Tony's just got a few more points. We will open up the questions if people have some more questions, and we will be finishing in a couple of minutes.
Yeah, so Sarah, so some of this work, Dale and I, as I said, worked with the Australian College of Rural and Remote Medicine under the auspices of the Digital Health Authority to produce an online learning module which goes through the principles of quality improvement map, that culture of improvement, developing a culture of patient safety, and the worked example in that module is this particular issue of uploading shared health summaries, and it goes through some of the principles of improvement and of leading change with regard to this shared health summary stuff. There's other parts to it about systematic management of chronic disease and some improvement ideas that other practices have put in place, and it also deals with the difficult problems of multimorbidity in patients with many health problems. And there's another section, another module on specific e-health details and the strategies that can be used in your practice. I think this module is good, but I would say that, but I do think it's good. But certainly the team at ACRM have produced it into an online experience that I think is really good. Now this is about, even though it's from ACRM, it's available to everybody to use, but it's targeted practice managers, practice nurses and GPs. You can enrol in that free of charge without being a member of ACRM. James kindly put the resource link there, and I'd encourage you to go and have a look at that. That's in the chat pane, and we can just Google ACRM eHealth enabled and it comes up the #1 here. That's the way you find stuff.
Great. Okay, so we do have question time now, and Tony, Sarah asked in the chat pane, just to confirm, can the GPMP nurse complete a My Health summary also during a planned consult?
Well, I think we've discussed that. The nurses can do the technical bit of uploading it, but it should be under the direction, immediate direction of the patient's usual GP. Now, there are exceptions able to be made, which includes remote areas or where the nurse is actually the primary care provider looking after that patient. But my understanding is the intention of the legislation is that it's a GP responsible for the content of the shared health summary, and therefore if I'm responsible for it as a GP, I actually want to be doing that bit of it myself. Now the nurse can certainly help improve the data quality and talk to the doctor or hit the buttons, but I want to know what's going up for my patients.
Great. So if anybody's got any other questions, they could just use the little raise your hand icon, which is on the toolbar. Otherwise, we might just keep going. Okay. Okay, so thank you so much for everybody. It was a great webinar. People have definitely been interactive and we really appreciate it. So thank you for attending today, and we hope that you found it informative and that you'll be able to utilise what Tony has shared with us in your own practice. So generally our last qiCommunity webinar is held in November. However, we have added a bonus webinar on the 7th of December. SA Country PHN has asked us to run an additional webinar for diabetes foot screening program, which is being implemented in South Australia. The program has been implemented to combat the fact that South Australia is faced with the nation's highest diabetic amputations. Although this webinar does have an SA focus, we have opened the invite up nationally, and the newsletter has gone out with a link if you are interested in attending. If, however, this is your last webinar for the year, on behalf of the Improvement Foundation, we wish you a very happy and safe holiday season, and we certainly look forward to your company in 2017. Thank you again, Tony, and thank you, everybody, and have a lovely Christmas.